I'm Joyce O'Shaughnessy, the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. Obviously, a very, very difficult situation, and thankfully, it's exceedingly rare. Breast cancers during pregnancy occur in 2 to 5 out of 100,000 pregnancies that occur. And so having metastatic disease is even less than that, fortunately. However, unfortunately, it does occur, and it does, obviously have to be fully evaluated. So the first place to start, of course, is a diagnosis. And it is safe to do ultrasonography. It is also safe to do mammograms with abdominal shielding. And it's also safe to do breast biopsy. There's a rare breast fistula, milk duct fistula, but that's very, very rare. So biopsies are certainly safe during pregnancy. And then, of course, evaluating the histologic diagnosis and the biomarkers, our state of biomarker suite, including the estrogen receptor, progesterone receptor, and HER2. Most breast cancers that occur in pregnant women are grade 3, poorly differentiated, and most of them are triple negative, although it is possible to have HER2 positive breast cancer or high grade estrogen receptor positive HER2 negative breast cancer. With regard to staging of a woman who is pregnant and she's now been diagnosed with, let's say, a locally advanced breast cancer, and there's concern about metastatic disease, it is safe to do a chest x-ray with abdominal shielding. It is safe to do a liver ultrasound, not a bone scan because of the systemic radionuclide. It is safe to do an MRI of the spine, for example, without contrast, looking for bone metastasis, and of course, physical examination. And so that will be the extent to which we'll be able to tell whether or not there's metastatic disease present when a woman is actually pregnant. Then the next question, assuming that unfortunately metastatic disease is discovered, the next question is, where is the woman in her pregnancy? And is she first trimester, second, or third? We know that we do have therapies that are safe to administer in the second and third trimester. Unfortunately, there are no therapies for metastatic breast cancer that are safe to administer in the first trimester. An important question is whether the overall prognosis from the metastatic breast cancer occurring in a pregnant woman is improved by terminating the pregnancy. One might think the hormonal milieu, for example, of pregnancy would be deleterious in terms of the outcome of the breast cancer. That does not seem to be the case, as you can imagine, from limited data sets that occur. So termination per se probably doesn't influence the outcome of the breast cancer. However, of course, the longer that therapy is postponed, then that could be deleterious to the health of the mother. And the indications for termination of the pregnancy are if, for example, a woman was in the middle of her treatment for metastatic breast cancer, and then she is found to be pregnant, for example, and so therapies would have been administered within the first weeks of conception. There's a great deal of concern about fetal injury, teratogenicity, and that would be an indication for terminating the pregnancy. The other is if it's felt that the metastatic disease is widespread enough that it would be deleterious to the health of the mother, that it could really adversely affect her breast cancer outcome from the metastatic disease by postponing therapy for many months to get her through pregnancy. If she's in the first trimester, that would be an indication for termination. These are very difficult conversations that take a long time. The woman has to be, of course, very fully informed. So if a woman is first trimester, unfortunately, that's a long way to go before a safe delivery, and therapies can't be given in the first trimester. So that may be, for many women, they would choose termination in the first trimester. In the second and third trimesters, there are therapies that can be administered to patients. They are not necessarily our optimal therapies for some subtypes of breast cancer, but they can be administered. So a woman who is very highly motivated to keep the pregnancy to full term could be treated during the second and third trimesters safely without concern about over concern about fetal harm. So some of the options would be anthracycline based chemotherapy, doxorubicin, cyclophosphamide with or without 5-fluorouracil. That's the one that is, those two, the FAC or the AC, are the two regimens that have the greatest degree of safety data associated with them. There are multiple now case reports of the safety of administering docetaxel or paclitaxel during a pregnancy. There are also case reports regarding the safety of carboplatin during pregnancy. But some things that are not safe, for example, are methotrexate. So the CMF regimen is not safe. Endocrine therapy, hormonal therapy is not safe. And that's problematic if a woman has ER positive, HER2 negative breast cancer, where the estrogen receptor may be the key driver of the breast cancer. And then also trastuzumab, pertuzumab are not safe during pregnancy because of polyhydramnios. Sorry, I'm going to change that again. I'm going to stop and say that again. It should be oligohydramnios. Sorry. Another therapeutic strategy that's not safe during pregnancy are trastuzumab and pertuzumab. And that's unfortunate for the patient whose breast cancer is HER2 positive, because trastuzumab causes oligohydramnios. So that is problematic. Nonetheless, having said that, a woman who is highly motivated to keep the pregnancy could be treated in the second and third trimester with FAC, for example, or AC on an every 3-weekly schedule. And FAC, for example, she could be administered 50 milligrams per meter squared of the doxorubicin. She could have 6, 7, 8 cycles of that, and could likely get to the point where the baby could be delivered safely, at around 35, 36 weeks, for example. Once a woman delivers her baby, then she can be treated as per any other woman with metastatic breast cancer. So there are really no contraindications once delivery has occurred. And of the children who are born when their mothers have received chemotherapy in the second and third trimester for breast cancer appears to be quite good. There really does not seem to be an increase in the rate of fetal malformations above that which would be expected in the general population, in the range of 2 to 3 per 1,000 children born. So that's good. And there are nationwide registries ongoing to be able to collect more data in that regard. But the data that exist are quite promising in that regard. So that is a bit of a summary of what we know about the approach to the woman who is diagnosed with metastatic breast cancer during pregnancy. And that can occur one of two ways. Either she is enjoying a normal pregnancy and then unfortunately is found to have a locally advanced breast cancer with metastasis, in which case she could begin therapy if she so chose during the second trimester. Or a more difficult situation is the woman who is being treated for locally advanced breast cancer, and then in the midst of the treatment is discovered to have metastatic breast cancer. And though the fetus then would have been exposed to carcinogenic treatments during the first trimester, that's a very difficult situation. And a woman would want a good discussion around that to consider termination at that point.